Shall we start?
Yes, ma'am.
Yeah. Welcome all the dignitaries, respected colleagues and viewers. Recent changes in medical education have highlighted the importance of learning and unlearning. We have to gather CME points to continue our practicing license. To address the need and demand of pediatricians practicing in periphery, our activity of journal journey was started. Thanks to Raigad IIP and our guide, Dr. Nimen Mohanty sir, and President Maha IIP, Dr. Gangolia, to continue it at Maharashtra IIP platform. I'm happy to invite Dr. Gangolia sir for his welcome address.
Thank you, madam. Good evening, respected dignitaries and dear colleagues. So this journal journey, the first day of every month, started on the Doctor's Day of year 2020, 21, and it went across the Raigad district for first 3 months, then across the Maharashtra state for the last 11 months, and now we have covered Gujarat state also, Goa, and we are extremely happy. Today we are having Telangana state participating in this journal journey. So respected dignitaries, we have our guide, Dr. Nimen Mohanty sir. He is always rock pillar to stand for these episodes of the journal journey, as well as today we have two dynamic Secretary Generals, Dr. K. Pawan Kumar of the Honorary Secretary General of Telangana State, known as PATS, Pediatric Academy of Telangana State, as well as our own Honorary Secretary General, Dr. Amol Pawar of Maha IIP, our state convener, Dr. Jay Bhandarkar, as well as today's speakers, Dr. Pradna Madam, Dr. Sapna Madam, two excellent experts, Dr. Om Prakash, as well as Dr. Amol Jai Bhai. And we are also having to grace this dais, I do see the newly elected CIP EB member, Dr. Jitendra Gawani sir, with a thumping majority as one as an EB member for 2023. Congratulations, Dr. Jitendra. As well, I do see here Dr. Snehal Nagre, EB member of our Maha AAP, as well our editor, Dr. Neha Singh, our today's whole backbone, I can say, after Nimen Mohanty sir, is the Dr. Chitra Madam, who has all the time, after all the presenters and fantastic work done by Dr. Chitra Madam in coordinating on communicating with all these speakers and everything all the time. And with that, so the journal reading, as we experienced in our PG days, we used to do in the journal club. So probably this journal reading is arose from that idea, and it was Jay who was the brainchild, and myself who decided to hold this with the help of Nimen Mohanty sir, and just whatever the articles we read, how to implement our general practice, whether it's useful in the general practice and how to go about it. We come to know from within a span of 10 minutes itself, 15 to 15 minutes from these stalwart speakers. So all the best wishes to the speakers. Today's speaker, Dr. Sapna Madam, Dr. Pradna Madam, and we will see the good session today. Thank you very much.
Yeah, thank you, sir.
1 minute, madam. Sorry to interrupt.
Yeah.
I welcome Team Maha IIP welcomes respected EB member from Telangana State, my dear friend, Dr. Sri Shailam Kottaru. Welcome.
Namaste,
sir.
namaste, namaskaram.
Welcome, sir.
Thank you.
Welcome,
Also,
Dr. Sri Shailam.
and Dr. Chitra Madam, I also missed the journey which we started from by our IIP Raigad, by our my president, Dr. Pramod Wankhede sir. Namaste, Wankhede sir. Yes,
Yeah,
yes.
thank you. Thank you, sir. And to improve the outcome of sick child, this program basically of Raigad IIP helps to get the well-honored research papers on this dais and to build up the knowledge in which we can use in our day-to-day practice. For making it possible, our Raigad IIP President, Dr. Pramod Wankhede, was also instrumental. May I request Dr. Wankhede to say a few words. Sir, unmute kara.
Thank you, madam. Thank you. Respected today's guest of honor,
Dr. Pawan Kumar, experts, Dr. Amol Jaibai and Dr. Om Prakash Jamadar sir, our main pillar, main guide, Dr. Mohanty sir, Maharashtra IIP President Gangulia sir, Dynamic Secretary Amol, Convener Dr. Jay Bhandarkar, and main driver of this journey, Dr. Chitra ma'am, Dr. Neha, and my co, Dr. Dhananjay Rajput and Vikas More, and our invited guest, today's guest, Dr. Jitendra Gawani sir. I welcome him and I congratulate him also for his extraordinary victory. And I also welcome Dr. Kotturu sir as our guest. I welcome you all. So this is, I think, last but one episode of this year of the journey. Actually, this is routing. Initially, it was in the Raigad district, then in Maharashtra, and then now it is intranational. It is going all over all India, I think. And I would like to see in all over India also, so that the knowledge, wisdom can be shared. We get to hear some different experts' opinion, and we increase our knowledge with that. I again congratulate both the presenter of this journey, Dr. Pradnya and Dr. Sapna. So anyway, I congratulate and thank you very much. Thank you, Kulkarni.
Thank you. Thank you, Dr. Wankhede. And may I request Dr. Amol Pawar to say a few words in short and give his blessings, because I am tempted to ask him to say something.
Thank you. Thank you, Chitra ma'am. This was a wonderful journey with Raigad IIP, and all you people have started in last year of Dr. Sunita Ingle madam's tenure, the journal journey. म्हणजे मराठीत सांगताना तर बऱ्याच लोकांना काय असतं हे काही माहितीच नव्हतं, आणि ज्यांना माहिती होतं ते उत्सुक होते की काय असतं नेमकं हे. तर जेव्हा जय सर आणि गंगोले सर बोलले की आपल्याला हे असं कोलॅबरेट करायचंय, तर सर म्हटलं काहीच प्रॉब्लेम नाही, आणि आपण सर्व विल आस्क ऑल द डिस्ट्रिक्ट OBs to give names of this thing, and with the help of EB CIIP from Maharashtra, all 5 EBs, they have helped us in getting the speakers, and we have selected experts also for these episodes, various episodes, and we have stuck with the first day of every month. We have this thing, means we have arranged these sessions. So I congratulate once again all the people involved in making this journal journey successful, and I welcome all the experts, delegates, and all the speakers on this platform. Thank you. Thank you from Team IIP.
Yeah, thank you, sir. And
madam, please.
Yes.
All these journal episodes are available on MahaIP YouTube channel, so one can subscribe and they can see all episodes. As well as Dr. Wankhede sir said this is last or second, but this is journal journey to be continued, and we should continue, Dr. Wankhede sir, and let us hope it will.
I also wish that it should be continued without any break.
Yes, sir. Pramod sir will continue next year also.
Yes.
With MahaIP.
Yes, definitely.
Good suggestions. And now may I request MahaIP editor and star member of Raigad IIP, Dr. Neha Singh, to introduce Dr. Pawan Kumar, our guest of honor for this episode. Dr. Neha.
Yes, thank you, ma'am. Thank you. Today we have with us Dr. K. Pawan Kumar sir. He is Secretary of IIP Telangana, Professor of Pediatrics, MNR Medical College. Also, he is Consultant Pediatrician at Omega Clinic. Sir has done Fellowship in Allergy and Clinical Immunology, Postgraduate Diploma in Pediatric Nutrition and Developmental Neurology. He is Instructor for BLS, PALS, NRP, ATM, RAP, ECD, Sir has received many awards like APJ Abdul Kalam Health and Medical Excellence Award in 2021, Best Researcher Award 2022, 18 and 16, National Award winner of Dr. V. Balagopalan Raju Gold Medal from Scientific Research Paper 2010. Sir has also received Y.R. Reddy State Gold Medal and Dr. Chandrasekhar Chaudhary Gold Medal 2009. Welcome, sir. Over to you. Kindly give your blessings, sir.
Yeah, thank you so much, Neha. I think greetings from Pediatric Academy of Telangana State. So Journal Journey, I think it's a blockbuster show. Everybody is eagerly waiting every month. So it's very close to my heart and is very popular across the country among the busy pediatricians who can't spare to read the entire journal. So you are bringing in 10 minutes how to go about it. Thank you so much for the entire team for making it a grand success. And it has a very good attendance with every episodes. I must thank Dr. Hemant sir. I think in the Noida Pedicon, we had a very good time during the cricket matches and all. And I must thank my dear friend Amol Pawar and for giving me this opportunity to be the guest of honor for today. And Maha IAP is always an inspirational for Telangana. So it is in the forefront in the country to share the quality knowledge and wisdom to all the pediatricians. Why I'm saying this is, I think there is special thanks I should mention to Chitra Kulkarni ma'am. For this 1 hour session, she has almost spent 1 month. She is behind our passionate speakers from Hyderabad, Dr. Pratnya and Dr. Sapna, who is going to present in a very good way, I think, under the guidance of Kulkarni ma'am. I think it's going to be a blockbuster event like it is before. And I also thank the experts for today, Dr. Amol sir and Dr. Om Prakash sir for their expert guidance. And first of all, and the last but not the least, I must salute the Nomain Mahanti sir, who is a professor emeritus. My salutations to you, sir, for guiding such a wonderful program. And I should congratulate the entire team of Maha IAP and IAP Raigad, especially for innovative ways of bringing knowledge to the pediatricians across the country. So wish you all happy and joyful learning. Thank you so much for inviting me.
Yeah, thank you. Thank you, Dr. Pawan Kumar sir, for those kind words. Friends.
Madam,
Yes.
we acknowledge the presence of our Chief Organizing Secretary, Dr. Milind Bharadia sir
Yes, sir.
also. And everyone is invited to Maha Pedicon 2022 at Nashik, and everyone should register. Welcome, Dr. Milind sir.
मिलिंद सर 2 मिनिटं बोला 1 मिनिट बोला.
May I request
Unmute करा.
Dr. Milind Bharadia sir to say a few words?
अनम्यूट करा सर.
Please unmute, sir.
Pallavi ma'am,
I
kindly
think
unmute.
Pallavi ma'am.
Palli madam.
No,
please
he
give
has
permission.
permission. He has permission, sir.
हाँ, करा सर.
Please unmute Dr. Milind.
हाँ.
Can you hear me now?
Yes. You are audible. Yes.
Good evening all. Basically, thanks for giving me opportunity to speak on this platform. I invite you all for the grand Mahakumbh Mela of a pediatrician at Nashik. And I sincerely request each and everyone to spread a word about the Maha Pedicon in all your pediatrics group at your district branch. Thank you. See you all soon at the Maha Pedicon. Thank you. Thank you, everyone. Thank you, Gamlia sir and Amol for this opportunity.
Thank you,
Thank you, sir. And friends, post-pandemic, we are now in a complex healthcare system. A life which we treat has a accountability and plus responsibility. A live example of these qualities is our state convener, Dr. Jay Bhandarkar. May I request him to introduce expert and first speaker.
Thank you, Chitra madam. At the outset, actually, I personally attended from my first day of PG all the general journey or sessions at the Solapur Medical College, and very fond of reading all journals as well as attending the sessions. So I thought almost 24 back, that was on Doctor's Day, and Dr. Gangulia pushed me, we should do it. And then I contacted Mohanty sir, said the excellent idea, and I was the first presenter. I might have remember or not. It's on the YouTube. I started this, and that share like that, मैं अकेला चलता रहा और कारवा बन गया. So I see that it is spread all over India also. Journal की बात ऐसी और CIP also does that. So thanks to all, basically, though I started it, the credit goes to all the team. Chitra madam and Neha, everybody they are behind this, and because motivating people and inviting the speakers as well as the finding the expert is always my job. They call Iled or Jay, these are the two topics and you want the two experts, and that uh, always all I'm blessed with our program with the beautiful or senior or very respected I think experts. And today we are also based with Dr. Amol Jaiba. Is from Mumbai and is the infection specialist. Does in the MBBS and disease DNB from Mumbai, and has done his international short course in the clinical tropical medicine, as well as is a fellow in pediatric infectious disease from Christian Medical College, very well known, well-known. Has several publications, scientific paper presentation achievements, and currently working as an infectious disease consultant at SSC Hospital. Mumbai, Jupiter Hospital, Thane, and in many other hospitals. So thank you, Amol, for accepting our invitation to come as expert.
Thank you, sir.
Dhanyavad.
Thank you, everyone.
Our presenter.
Our presenters, yes, thank you. On the outset, Dr. Pradnya Fawali, she is from Hyderabad, done as graduation and fellowship in neonatology from Hyderabad only. And she is working as a neonatologist and in charge of NICU at Shalini Hospital, Hyderabad. And she has won excellent medical excellence award from Minister of Child Welfare, Telangana State in 2021. She's won gold medal for the presentation of reactive thrombocytosis and predictor of serial bacterial infections at the Twin City Conference, as well as she published chapter on the approach to the neonatal hyperglycemia in the textbook of pediatrics and neonatal emergencies. She had also international publications, as well as she has done work for the Neonatal Network Journal also. And she was a faculty and co-coordinator for the Advanced NRP as well as Asia Specific Pediatric Conference, and faculty for international workshop on therapeutic hypothermia, central axis. So I can say the very expert, as is a very enthusiastic presenter. I attended our training session was there, and she meticulously prepared it and sent to our Mohanty sir, corrected it, and so thank you to Dr. Pradnya for joining today's session. Thank you. Over to Dr. Chitra Madam.
Thank you. Dr. Pradnya, you may start your presentation, please. Share your screen, Dr. Pradnya. Thank you.
Pradnya ma'am, kindly unmute yourself also.
Hello everyone, a very good evening. Myself Dr. Pradnya Prakashwali, giving you warm regards, and I'm here today to present a very important topic, and my topic for the day is duration of antibiotic therapy for bacterial meningitis in young infants, those less than 3 months of age. It is systematic review. So the source of article, the author of this article are Matev and Entering et al. And it is recently published on 5th of October 2022 in the Journal of Pediatrics. We all know that Journal of Pediatrics is a very well-renowned journal. It is an official peer-reviewed journal of American Academic Pediatrics, which is published since Jan 1948. It is the journal with one of the highest impact factor of 7.12, and it is indexed by major biomedical and scientific indices like Medline, PubMed, and ISI Thomson's. Now coming to the introduction of my topic.
Change the slide.
The full screen.
Full screen and slideshow.
It's not moving.
So it is full screen only, sir?
No, not.
No,
It is-
no.
Then you have to stop share.
You have to go back.
Just see you will see the two PPTs. One open one. Just click that. Pallavi madam, please guide.
Yes, sir. Yes, sir.
When you share the screen, you will see two PPTs of the same PPT open. Share that.
Yes, ma'am. It is
Yes.
full screen now.
Yes.
It is
Yes.
full screen.
So coming to the introduction of my topic, we all know that bacterial meningitis is a very severe infection of CNS with the highest incidence during the neonatal period. The prevalence of bacterial meningitis in developed countries is somewhere around 77 to 80 cases per lakh live births, whereas in low resource countries like ours, it is as high as 4.9 to 5 cases per 1,000 live births. The mortality rate ranges from 6 to 15% in high income countries, whereas in low and middle income countries like India, it is as high as 40 to 58%. Coming to the morbidities, the acute complications were seen in 54% of children in the form of ventriculitis, hydrocephalus, brain abscess, infarct, etc. And 20% of the children had long-term complication in form of neurological deficit, hearing loss, mental retardation, seizure disorder, etc. The slides are not moving, ma'am.
Just double. Yes, it will.
Yeah. Now coming to the this topic, why this topic was selected for today? Because we all know that meningitis is very common in low economic countries with high mortality and morbidity. Hence, the aggressive treatment with good antibiotic for appropriate duration is required. But most of the studies which are available and most of the data which are available with us is from the Western countries. The prevalence of this disease, the type of flora, the type of microorganism causing meningitis in those babies, their antibiotic focus and treatment policies are entirely different than that of us. The guidelines which are available for prolonged treatment of meningitis, these are based on expert consensus rather than clinical trial. And the treatment recommendation which are especially present in the young infants, they are mainly derived from the studies in older population. Hence, we do not have any recommendation how to treat the babies, younger babies with meningitis. So today's topic is selected to discuss so that we can come to a common consensus to decide the duration of antibiotic to treat the smaller babies with bacterial meningitis. So now coming to the aim and objective of the study, it was done to review the literature on the duration of parenteral antibiotic therapy and to know the outcome of bacterial meningitis in the babies less than 3 months. The methodology, the data was derived from the important sources like PubMed, Embase, Cochrane Library, and relevant publication were searched from June 2020 to 31st May 2021. All the study types published in English in peer-reviewed journals were systematic review. The PRISMA guidelines for systemic reviews were followed. Now coming to the inclusion criteria, obviously the babies less than 3 months old with bacterial meningitis in whom the duration and route of antibiotic therapy were reported, like VLBW, ELBW babies, babies with congenital malformation, and those with neurosurgical conditions were excluded. The primary outcome was, and secondary outcomes were reported as alteration of hospitalization and any neurological sequelae if it was present. Coming to the statistics part, the data on the exposure, primary and secondary outcome, and quality appraisal were compiled into summary tables. A total of 2,195 studies were retrieved, out of which only 280 studies were selected for full text review. 32 were qualified for inclusion in this study which included 1 randomized controlled trial, 25 cohort studies, and 6 case series. In the RCT which was studied by Mathur et al. From India, 70 newborns with presumed bacterial meningitis were randomly allocated either to study group or control group. In study group, the babies received antibiotic for 10 days, whereas in control group, the babies received antibiotic for 14 days. The baseline characteristics for both the groups were similar. Now coming to the diagnostic criteria of bacterial meningitis in the study was a CSF WBC count more than 32 cells per cubic millimeter in a sick baby with at least one of the following criteria. The total leukocyte count should be less than 5,000 or more than 20,000. Immature to total neutrophil count ratio should be more than 0.2, along with the raised inflammatory marker in the form of raised TSR or raised CRP. The result of this RCT demonstrated that only 2 patients had CSF culture positive bacterial meningitis, and both these patients were randomly allocated to the control group. 11 patients, both combined from control and test group, were positive, had positive blood culture. 3 babies from 35 babies in the control group had sepsis within 28 days of enrollment to the study, whereas none of the baby in the study group developed any sepsis. There were 2 deaths noted in control group and 1 death reported in the study group, but all these deaths were more likely due to severe sepsis. None of the patients from the control group and only 1 patient from the study group had abnormal BERA. So the conclusion of this RCT was 10 days course of parenteral antibiotic therapy for newborn bacterial meningitis was as effective as a 14 days course. And it was also seen that there was no significant difference in the mortality rate in both the groups. Hence, coming to the discussion and conclusion, we all know that very few studies are available which evaluate this question. Only 2 studies, 1 randomized control trial and 1 cohort studied in depth the relation between the duration of antibiotic therapy and the outcome of the disease. And both of the study concluded that longer courses of antibiotic therapy is not associated with any extra improved outcome or any extra benefit to the patient. Remaining studies like cohort studies and remaining studies did not come to any conclusion because of variability in the data, small sample size, and lack of stratification of the outcome. Most of the study had also had a moderate to high risk of bias. So considering the risk and cost factor, we concluded that there is a high pressing need for high quality research to further address this question on treatment duration of bacterial meningitis in these young infants. So dear friend, my take home message from today's journal club is bacterial meningitis is very common in low to middle income countries with high morbidity and mortality rate. If left untreated, it will be life threatening. Hence, optimal treatment course with appropriate parenteral antibiotic duration has to be formulated. From available data, it was seen that there is no difference with 10 days or 14 days antibiotic course, either in the terms of outcome or mortality. And we all know that inadvertent use of IV lines will lead to unnecessary infection, thrombophlebitis, and pain in the children and of the antibiotic. So we want to conclude from today's journal club is that if the meningitis is present but without any complication, 10 days IV antibiotic should be sufficient. And if the meningitis is present with some meningitis is due to some atypical organism, or if there is recurrence of disease, then only the prolonged antibiotic therapy has to be considered. So my dear friends and all practicing pediatricians, let us follow this uniform guidelines to treat these babies with bacterial meningitis so they can get more benefits and we can avoid or minimize antibiotic resistance in future. Thank you.
Thank you. Thank you, Dr. Pradnya. And it was a perfect presentation. And now may I request expert Dr. Amol to opine.
Yeah, so Dr. Pradnya has presented very well. And she has also explained the pros and cons related to the studies.
Stop sharing, Dr. Pradnya. Please stop sharing your presentation.
Yeah.
But looking at the study population, it's very difficult to
Amol sir, unmute sir.
Okay, it's very difficult to
Amol sir.
Sorry for the disturbance, my kid came in between. So there are 2 things. It's very difficult to generalize this study as compared to the general population, because here only if you see only 2 patients were having a CSF culture positivity, and those were also not included in the control treatment group. So they were randomized to the control group. So it's very difficult, like to say the shorter duration of therapy will really works, because there was only that one study, that is Mathur et al. Was there, and I think there were only 2 studies which showing this, as you said, they were directed the duration of treatment with the clinical outcomes. So as ma'am said, like the children affected with a meningitis without complication will receive 10 days of antibiotics. It's okay for a gram positive organism, but if it is a E. coli or gram negative organism, still I think we should give like a 3 weeks of antibiotics, because with these guidelines it's very difficult to come at a conclusion, because as she said earlier, our guidelines are derived from the older children, and they have done, like, there are 2-3 randomized 2-3 meta-analysis are there, done in 2009 and done in 2011, which has done some 5 RCTs, and they have shown the short duration and long duration of the treatment. But still, I think for gram negative organism, 10 days of antibiotic will be the still this thing. Here we go with the CSF clearance of the organism. Is there any complication associated with the baby? Because sometimes they will develop hydrocephalus, ventriculitis, and that time the course will be extended up to 6 weeks or more than that. Otherwise, she has presented very well.
Yeah, thank you. Thank you, Dr. Amol sir. Now it is seen that we have to deliver the healthcare which is perfect for our patients, our administrators, and the lawmakers. So this paper was certainly a thought-provoking one for that, I suppose. Now we move on. May I request our spiritual Raigad IIP Vice President, Dr. Vikas More, to introduce our second expert, Dr. Om Prakash Jamadar, and second speaker, Dr. Swapna Reddy. Over to Dr. Vikas.
Yeah, thank you so much, ma'am, for your kind introduction of me as a spiritual doctor. Good evening, everyone. On the behalf of IIP Raigad, I am Dr. Vikas More. I am really happy to introduce Dr. Om Prakash Jamadar, who is my not only a good clinician but also my best friend. We all know him with his best clinical background. He has done his MRCPCH from London. He was selected for 2-year neonatal fellowship program in UK. Has done his DCH from UK. Right now, he is working as a consultant at Apollo Hospital, Navi Mumbai. He is also national faculty for basic and advanced neonatal stimulation program, resuscitation program, and also neonatal simulation program. And secondly, we are also having a good speaker from Hyderabad, Dr. Suvarna Reddy. She is associate professor at Swapna Reddy, done as DNB Pediatrics and working as an associate professor in Department of Pediatrics, Apollo Institute of Medical Sciences and Research in Hyderabad. Her area of interest are in developmental pediatrics and pediatric critical care. She will be presenting the topic on preterm enteral micronutrient supplement. It is a very interesting topic to all of us. I request Dr. K. Swapna Reddy to start her presentation.
Good evening, sir. Thank you for that introduction. Now I'll be sharing my screen. Good evening, sir, and good evening to all the dignitaries present over here and to all the viewers. Sir, can you all see my PPT?
Yes, we can.
Yes, Swapna. Yes, Swapna. Go ahead.
And thanks for the Maha IAP, sir, for giving me this wonderful opportunity. The other day, when I started from my hospital, I got a call from my postgraduate telling, ma'am, oh, we already discharged that preterm baby, ma'am. What advice should we give when we are discharging that baby? Then I asked my postgraduate, yeah, what advice do you want to give? Then he said, ma'am, should we give any micronutrient supplementation to the baby? Then I asked my postgraduate, oh, do you think is it really required? Is it your assumption or evidence? As we see, today is everything practicing in the pediatrics or any other medicine, it is evidence-based. So today we'll see what evidence says about the enteral multiple micronutrient supplementation in a preterm and low birth weight infants. And this is my topic for presentation today. This is a systemic review and a meta-analysis done. It is published in the recent AAP publications, volume 150 in the August issue. So moving from the era of survey to thrive, as we've all seen, the preterm births account for 12.6% of all births, and more than 1 million infants die every year because they're born preterm. And those who survive are increased risk of morbidity such as malnutrition, vision loss, hearing loss, or neurodementia. But we have all seen that the neonatal mortality rate and morbidity rate is improved. And now our focus and emphasis is mainly on the thriving of these preterm and extremely low birth weight babies. So we all think that there is special nutritional requirements of preterm babies. But do we know why we have high nutritional requirements in these preterm babies? That is, they have lower level of nutrients in the body stores at birth, or because of the immaturity of the body systems and the need for the rapid postnatal growth and occurrence of acute illnesses. So that's why we think the human milk may not be sufficient to cater all these needs. So we are thinking, what is the role of multi-micronutrient supplementation for these infants born for their development? As of now, we don't have any specific consensus on this micronutrient supplementation. There is wide usage of multi-micronutrient supplementation in preterm and the low birth weight infants globally with little evidence on their benefits and harm. But only we have consensus and globally followed protocols for very minimal micronutrient supplementations like iron and vitamin D. So the purpose of the study is to review, is there any evidence for the sufficient evidence for the micronutrient supplementation in the preterm and low birth weight benefits? Does it really benefit the outcome in the respective to the growth and the neurodevelopment? So the aims and objectives of this study is to assess the effect of supplementation with 3 or more micronutrients compared to no micronutrient supplementation in human milk fed preterm and low birth weight babies. So the primary objective was to assess the effect of this in terms of the mortality, morbidity, growth and neurodevelopment outcomes in the preterm or the low birth weight infants. And the secondary objective were to determine the optimal time of initiation, dose and duration of multi-micronutrient during infancy. So the methodology used was, there's a comprehensive search was conducted in the Cochrane Central Register of Control Trials, 2016 issue 3, Medline via PubMed and Embase from inception to March 24, 2021. The studies included are all were randomized control trials or quasi-randomized, including cluster randomized trials, but not crossover trials. The protocol for this review was registered in Prospero, and the grade criteria was used to judge the quality of evidence. So the inclusion criteria was all the low birth weight infants and the preterm infants who were fed on mother's own milk or the donor human milk were allocated into 2 groups. One group was allocated to receive the enteral multi-nutrient syrups and compared to with a control group where they were given a placebo or no nutrient supplementation. The other was allocated to different multi-micronutrient syrups. This was done to compare the dosage, duration, and timing of initiation. So these multi-micronutrients were defined as supplements containing at least 3 or more of the following micronutrients like vitamin A, vitamin D, and B vitamins, iron, vitamin C, and zinc in one formulation. The exclusion criteria was the studies in which MMN were mixed with multi-component breast milk fortifier and where infants were fed with formula milk were excluded. So the outcomes measured were a data on subgroup of 414 preterm or low birth weight infants were reviewed from 2 randomized control trials. So there were 2 trials in this. One is the Tanzania trial and the other is the Mexico trial. In the Tanzania trial, the MMN supplement used was vitamin C, E, thiamine, riboflavin, niacin, pyridoxine, folate, and vitamin B12. So there were 4 groups. 2 groups were put in the intervention group and the other 2 were in the comparative group. The intervention group had either MMN alone or MMN plus zinc. The comparative group had the zinc alone and placebo. In the Mexico trial, the MMN supplement had the same nutrients as that of the Tanzania trial, plus additionally they've added vitamin A, vitamin D, iron, zinc, and magnesium. The intervention group had MMN, vitamin A, and iron, and the comparative group had vitamin A and iron. So the outcomes were measured in the growth outcomes and the neurodevelopmental outcomes. In the growth outcomes, the number of participants were around 350 to 392, as you can see in the table. And they have taken the weight for height, height for age, and the weight for age Z score. And the follow-up was done, and they have seen the change in the Z scores between the mean enrollment at the starting time of 7 weeks to end enrollment mean, which was 91 weeks. As you could see, the risk difference with supplementation, the confidence intervals are very wide, and the grade of evidence is very low. So using the grade criteria, the quality of evidence was found to be low to very low for all the outcomes in the growth outcome, what we have seen. And the trials also used various types of doses of MMN supplementation. Though the heterogeneity in the meta-analysis was low, the I score is 0%. For the growth outcomes, these effects were all uncertain of clinical evidence, and the confidence intervals were wide and crossed the line of no effect for all domains. In the neurodevelopmental outcomes, they measured using the Bailey scale of infant development scale 3 scores. In that, they used the fine motor, gross motor, expressive language, receptive language, and cognitive follow-up. The number of participants here were only 27, and the follow-up was done at the mean of 78 weeks. Here also we can see the confidence intervals were very wide for each of the outcome. So for the neurodevelopmental outcome, there's a small increase in all clinical scores that may be of clinical significance. The confidence intervals were wide and crossed the line of no effects for all domains. And the infants who were enrolled were only 27, and the results were of very low certainty. So as what we can recommend is, based upon this systemic review, as far as now it is, currently routine supplementation of other micronutrients cannot be recommended in preterm and low birth weight babies because of the low to very low evidence. We need a multimodal approach, at least including the dietary assessment and laboratory biomarkers, to ascertain the status of vitamins in preterm babies. And also in preterm babies, we don't know the enteral absorption of these fat-soluble vitamins, which is due to reduced bile salt concentration and pancreatic enzymes. So presently, we have only consensus available for supplementation of vitamin D and iron. Thank you, ma'am. Thank you, sir.
Thank you. Thank you, Dr. Swapna. Will you please stop the sharing?
Yes, ma'am.
It was an intelligent and effective presentation for this topic. Thank you once again. And may I request Dr. Jamadar sir to give his expert comments. Dr. Om Prakash.
It was a very good presentation, and I will say it is a very practically important and relevant topic for all of us, because I'm sure as she started with the presentation, all of us do give supplements of vitamin D as well as the multivitamin for all the patients. Now, as the evidence is coming up, recently we did discussion about doing the cord levels of vitamin D for preterm babies, and then accordingly we are going to decide how much vitamin D is required. particularly for the preterm babies, there's a study coming up. Instead of giving for 1 year, that is a standard recommendation what we follow, we are planning to give it for 2 years. And then we need to do regular vitamin D levels, particularly for these preterm babies. And so it is important for us as much practically possible to monitor the growth. And it's not just the digital growth in terms of the weight and the length, it is the developmental assessment is also equally important. I remember a trial, I2S2 trial, which we did in UK, where we tried to find out whether there is any role of iodine supplementation for all these preterm and particularly IUGR babies, and developmental assessment subsequently around 2 years, but it has not shown any significant difference. So it is very difficult to do studies of the micronutrients and see the effect of the micronutrients, because there are multiple bias factors are there in terms of the milk that baby is getting, in terms of their environment, in terms of their genetic potential for the growth. So, but whatever the information we are available, whatever the evidence what we have available, only the iron supplementation and I will say vitamin D supplementation, these are the two confirmed things. Zinc is another thing which is coming a big way in terms of immunomodulator, as well as in particularly for the all preterm babies in particular. So that is in process, I will say. But other micronutrients are very difficult. There is some role of vitamin E and vitamin A, particularly in preterm babies, in terms of the prevention of chronic lung disease, as well as ROP prevention. So there is still a lot of work need to be done, but it is practically difficult to find out the exact values of the micronutrients that they require. And in terms of the side effect profile, when we are thinking of fortifying the milk with these micronutrients, we need to be careful in terms of the osmolarity, because the multivitamins have got the highest osmolarity in comparison to any other medicines. So particularly the babies who are preterm, who are IUGR, in that situation, we need to be careful when we are thinking of adding this fortification.
Yeah, very good point, Doctor. Here we come with the end of the presentations. Any questions in chat box, Dr. Jay?
Ma'am, I have a question for sir, ma'am.
Sure. And I also spot Dr. Mahesh Mohite. I request him to ask him some questions. Dr. Mahesh?
No, Dr. Sepi want to ask first. Let her
Yeah,
ask.
she will. Dr. Swapna, please go ahead.
Sir, I just wanted to know, if we want to do a zinc trial on this preterm and low birth weight infants, what would be the correct methodology or the test we have to do for the zinc estimation in these preterm babies, sir?
So I not came across a trial where they are tried to measure. I know a trial about cord vitamin D levels and the postnatal assessment of vitamin D. I need to check whether we have got standardized values in terms of the serum zinc levels, and at what stage we can measure them.
Okay, sir. Thank you.
Dr. Mahesh?
I had maybe question come comment, you can say. The first study was based on certain diagnostic criteria for pyogenic meningitis, where they mentioned cell count more than 32 and TNC less than 5,000, more than 20,000, and I suppose another few things. Are they in a today's era sufficient to diagnose pyogenic meningitis? For one simple reason, as we all know, neonatal meningitis is part of a bigger spectrum of neonatal sepsis most of the times. Isolated baby coming with neonatal meningitis is rare. Rather, it's a sepsis in which we investigate and find pyogenic meningitis. And the today's era where you have, though culture positive may be low, majority have blood culture positivity. In fact, in a neonatal pyogenic meningitis, blood culture positivity is almost to the tune of 40 to 60%. Om Prakash is there and even Jaiva is there. They can comment on this. So we have reasonably good positivity. Why your study showed only 2 cases come positive and rest majority being based on cell count, which has no definite evidence today as far as diagnosis of pyogenic meningitis? I mean, I think the basic criteria to diagnose pyogenic meningitis itself can be challenged in this case. Can you have some light on that?
Dr. Amol, can you comment?
As sir said, like you have to see like the child is having a sepsis. You have to say according to the age group how much is the cell count to define, and now along with the blood culture reports and CSF culture reports, that we can do another biofire markers to give like a adjective support to the diagnosis. But sir, as sir said, those studies are done in 2011, I think 2011 or 10, and they were having their sample size was also less, I think 70, out of which only 2 were CSF positive, and remaining 11 were blood culture positive. So over a period of time, the diagnostic has evolved, and the Vitek 2 or Phoenix, those systems has getting more accuracy over a period of time, and the biofire, all the film array. So we are getting nowadays a higher number of results to be getting a positivity.
Another question or comment is for the second study, again on the methodology. Where I don't know, I missed that part when the study was conducted. In today's rational and ethicality, when we have a study group and a control group of giving the nutritional supplement and other not getting nutritional supplement. So a control group not getting vitamin D and iron or those kind of important micronutrients. Is it rational and ethical at all to have that? That's my first question. And second question is, why such studies are conducted only in the smaller country like Tanzania and Mexico? Why they are not controlled? Why they are not conducted in the advanced world? Because these results you are extrapolating to the world. Like you have vaccine studies, always Gambia. Gambia's major economy is on the vaccine studies only. Gambia gets money only from vaccine studies. All guinea pigs are there. And are we rational in extrapolating those results to the rest of the world, which has got a huge data? So why, I mean, can we really extrapolate those results to the rest of the world where they are not tried? Some critical care studies are conducted in sub-Saharan countries. I fail to understand. I understand it's like a simulation training being given in the Western world, and Indian, we still don't have simulation because we've got a lot of subjects here to kind of work upon. So can we really extrapolate those results to the rest of the world, whatever you get in those poor countries? Because there it's rampant, and as kind of the epigenetic factor, because for generations and generation they are deficient, and their kind of genes are accustomed to these deficiencies over the time. So can we really extrapolate those results to the advanced world where no such deficiencies probably occur? So that's the question.
Yeah, it's a very good observation, and I request our guide, Dr. Mohanty sir, to comment on this.
Thank you. Dr. Mohite has brought out very, very important issues. See, please understand that these studies are all retrospective studies. They are not prospective ones. Whatever studies were available, they were taken together for a systemic review. As it is, what studies were available, they were taken as such. And who can be included in the studies? Where the methodology is most common. Only those studies will be qualifying for inclusion in the study. So it's not that, suppose you do a study like this prospectively, probably will not do in this manner. This has been done in low income countries quite about 10 years, 15 years back, because they won't get such studies in the Western countries. They have selected these studies, whether without this, let's see what happened. They're retrospective studies. That was it. About zinc, I must say, it is not now the recent papers, Cochrane review says zinc is not useful. But in countries where the soil is deficient in zinc, this is recommended, particularly in India and in Himalayan, sub-Himalayan areas, and certain of the Asian countries. Our soil is deficient in zinc, and mostly our vegetarian diet, there the zinc is recommended. Otherwise, now it is being abandoned in the rest of the world. Zinc may not be useful. And to conduct such a study, we have thought here in MGM also, but the cost is very prohibitive. To do absorption tests and all, very, very costly tests. So in mass scale, it is beyond us to do this. And we know that the zinc is required in this region. So we didn't think of this thing, this zinc study. That's it.
Yes, Dr. Om Prakash, our observation is that we do supplement all multivitamins, especially in preterm, we give A and E also. And like what we give vitamin K as an essential newborn care, all these multivitamins are in essential newborn care. So what is the point of this study?
So, before that, I just want to come back to point taken by Mohit sir, why these studies are conducted in the third world countries. So if you do the observations of all these studies, the NICU studies, PICU studies, or anything for that sake, in fact, this therapeutic hypothermia trial, it's very difficult to understand a therapy which is helpful in one world and which is not helpful in the other world. So that means there are multiple local contributing factors are there. As Mohit rightly said, the diet in that part is different and ours is different. So it may be found to be helpful for us in comparison to the other part. Why they are conducted here? Because one is the easy availability of the population. And if you give anything free of cost to these people, or maybe some incentive, they accept it better in comparison to Western world. I remember to take one permission to do one trial in Western world will take you ages. But on the contrary, even on a guinea pig also, if you want to get a permission to do a trial, it is quite difficult task in Western world because they have a different ways and standardized. But if you do in any other countries, South African and sub-Saharan areas, you can get it easily. That may be the reason that what I feel that they are done more commonly in these all poor countries where we can give some incentive and then you can carry forward. But extrapolation of data, I will be careful because it does get extrapolated, but it is not fair, particularly something where the nutritional deficiencies are common in these areas. That is one thing. Second thing, now as far as supplementing these neonates with these micronutrients, so yes, practically we do supplement still. And as we agreed, even the recent IAP guidelines, they do recommend vitamin D supplementation for all these babies, vitamin iron supplementation for all these babies, and even calcium supplementation for initial 3 to 6 months based on how small babies are there. But multivitamin supplements is a kind of a practice, but not much evidence available for this.
Sir, I have a question. When we were discussing and concluding the topic on bacterial meningitis, Amol sir said ki in gram-negative infections, we have to give for little more duration. Sir, but many of the time CSF culture to almost will be negative on almost all the babies, and blood culture also is rarely positive, sir. So in this scenario, how to decide whether these babies will require longer therapy or shorter therapy would be suffice?
Dr. Amol, are you responding, please?
Dr. Amol, please respond.
Yeah. Can I repeat your question?
Sir, we were discussing regarding the treatment of
My connection
bacterial
is not stable,
meningitis.
so in part.
Sir, we were discussing regarding the treatment of bacterial meningitis, sir. So you said if gram-negative organisms are there, we have to give it for longer time. But most of the time, the CSF culture will be sterile, and even blood cultures are negative for most of the time, sir. So how to decide like whether these babies will require for longer duration or not?
Yeah. So your question, what you ask is for the gram-negative, and you are asking when the culture is sterile or CSF is sterile, then there is no question of a gram-negative organism. If your culture, any one of the culture like blood culture or CSF culture shows E. coli, Klebsiella, then you give 3 weeks till it is the norm. And just I said, like on the basis of 2 patients or on the basis of Western data, our ethnicity, genetics, everything varies. So we need studies for that, and we cannot generalize that 10 days for everything. The 10 days they are suggesting those are uncomplicated, culture negative, and gram positive organism, it's okay. But still gram negative organism, everyone is the like 21 days of antibiotic is the still the norm. If anyone can add to this, it's okay. Means because
So
we need a randomized study in our population, but the thing is that for like a duration of treatment and clinical outcome, and giving a shorter duration of treatment to some neonate and not giving, so there are these things are very ethical. Means even to do a randomized control trial, ethical committee will not give like why to give these children shorter duration, because still those are like preemie babies or new term babies, and there are chances of high mortality. So we need good data for that, and need more studies. Because if you give a 10 days and the child is not evaluated after that, that can cause a partially treated meningitis and will come with a neurosequelae. So all the studies what you have shown, they have not done any post 30 days analysis data or assessment of a neurosequelae. So that is what my this thing is, that opinion is that we can treat, but it's okay if the culture is negative, blood culture is negative, we don't have evidence, and on the basis of clinical scenario, if you are treating 10 days is fine. But if the blood culture, CSF culture is positive, it's prudent to give a 3 weeks and assess the child, and over a period of time you also needs a assessment of that child post treatment.
Okay, nice discussion going on. Any question in chat box? And Dr. Mahesh Mohite wanted to again contribute something. He had raised his hand.
No, I think Dr. Mohanty has already said. I just wanted to put a point there that when you're looking at the nutrition and kind of a social trends or food trends in the particular area. So by this time, we know that there are some epigenetic factors who develop when the same deficit goes on generations. And there is a big trial during the Second World War. A particular part of the Europe was sort of blocked from food supply. I don't remember the particular area, but this was somewhere in 1940s. And for almost 2 years, there was severe drought in that area. And they followed those mothers who were carrying in that particular period, almost some 40,000 members. And they delivered the IVGR babies. And these babies were followed further for next 2 generations. And instead of giving complete nutrition to these babies, they went on to deliver low birth weight babies. So what I mean to say, a prolonged nutritional deficiency gets into your genetics rather than just a physic. It's not a phenotype, it's a genotype also which changes. That's where I said, when you're conducting such trials of nutritional deficit or supplement in the areas which are for generations already deficient, how that reflects, how that response can be extrapolated where the genetics is tuned for a sufficiency. How can you compare a sufficient kind of a nutrition genetics versus insufficient for generations nutritional genetics? That's my question. I have no doubt what Dr. Mohanty said is it's a retrospective, but even in retrospect, I believe that you can have that kind of a equality between those 2 kind of a subsets of population, which can be compared with that. So you may not get the same results. That was my question.
Yeah, agree totally. Now we are coming to the end of this session. And may I request?
Just one comment, madam.
Yes.
Just one comment.
Yes, doctor.
I will say the growth chart which are different in Indian scenario and the Western scenario, that itself gives us answer what sir is commenting about.
Absolutely. Absolutely.
Agree. Agree totally.
I'll just say
that's one more comment. That's a very reason the Indian population low birth weight is brought to less than 2 kg, unlike the Western world where it is 2.5 kg. Because we have accepted that nutritionally low all along. And that's what is, that's the reason you cannot compare these 2 populations. Am I right,
Yes.
Doctor? I think the criteria for low birth weight, now we are switching back.
Yeah.
So far, for years, together we have been considering less than 2 kgs low birth weight, not 2.5, unlike the Western world.
Our request to our guide, driving force behind this journal journey, Dr. Mohanty sir, please give your valuable comments.
Anay, I'm very happy. It generated a lot of discussions. First of all, nothing to comment on these papers. They are as it is published from a very reputed journal like Pediatrics of the American Academy of Pediatrics journal. What the selection of these topics are meant for, that they presenters should try to pick up what are the lapses of these also, what are the lacunae in them. These are not ideal studies. No study can be ideal. In over a period of time, it will be questioned. So whether they are trying to bring out the positive, the methodology, or the lapses or lacunae in the methodology. Suppose you have to conduct a study like this tomorrow, what the methodology you will adopt. This will come to your mind. And you see these studies are only very simple studies. Maybe it was because in third world countries, but they have selected now, this is published in last month only in pediatrics. So they are definitely relevant, and it shows that these are in our area. They are recommended. It's not recommended. It's a kind of larger studies are required. Nothing recommendation comes to what gives a lot of food for thought in this respect. In our area, actually, if the epigenetic scenario or say background is different, we should think of conducting such studies. Maybe not that we don't give anything wherever the national recommendations are there, vitamin D and iron. We should give this thing to the control also. And the study group, you don't give other things. So that's a design should be that the ethics committee approves it. So here the practitioners can certainly conduct the studies like these 2 studies have been done to be published, and maybe in our scenario, in our area, our region, what should be the ideal thing, the larger study. If you cannot do so many studies, so many subjects, but we can do multicentric studies in different areas. We can collaborate with our general practitioners, practicing pediatricians. Beautiful studies, larger studies can come up certainly, and can give a certain recommendation with evidence. That's what we are selecting such topics. We should it should generate discussions. Not every ideal study, it will not generate any discussion. No, will not enjoy. Thank you very much for everything. Thanks very. I will thank the presenters. They have brought out things very well. Okay.
Yeah, thank you, sir. And now may I request our state convener, Dr. Jay Bhandarkar, to give away vote of thanks. It was a very lively discussion.
Thank you, Chitra madam. At the onset, I thank you, Dr. K. Pawan Kumar sir, from Secretary of Telangana District IIP, for esteemed presence in this session, and our both experts, Dr. Om Prakash Jamadar and Dr. Amol Jaibhai from Mumbai, and both presenter, Dr. Pradna and Dr. Sapna, for beautiful presentation. And thank you to our Neman Mohanty sir for all this support and guide throughout the year from the since first episode of our Journey Journal. And thank you to our own IIP President, MAIP, Dr. Hemant, for supporting, and Dr. Amol, for Secretary, for always supporting all the activities. And thanks to Neha for wonderful all messages and other support, and as well as and the outside, very thank to the Vishal for 11th hour preparing all the CV slides and other thing. And क्या कहने चित्रा मॅडम की उनके वजह से ही कार्यक्रम सुरू है. आम्ही फक्त निमित्त मात्र सुरुवात केलेली आहे, पण ज्या पद्धतीनं जे केलं जातं म्हणजे फॉलो केलं जातं आणि ऑल ट्रेनिंग सेशन अदर थिंग्स. So thanks from bottom of heart for continuing this beautiful journey, and as well thanks to all the delegates for presenting in large number, and absolute thanks to Dr. Mahesh Mohanty sir, always is there for the lively discussion and pointing out me. I think the main we all of you know the aim and objective of this journey is to have a discussion. And sir, Neman Seven said that topic or that I think study may not be very perfect, but that create lot of discussion, and that gives, I think that stimulates all of us to read more and more and follow in our practice. And thank you to Pallavi Dharmadhikari for this digital support. And thank all of you for even Raigad IP, Dr. Wankhede sir, Dr. Vikas More, Dr. Dhananjay Rajput, our secretary, for doing this wonderful job throughout the year and supporting all this Raigad IP and MyIP activity journals. So thank you all of you again, and I hope all of you join even other sessions also. These are also very we do wonderfully of MyIP. And so good night from MyIP and Raigad IIP, and let us meet again and again. Though we are end of year, I think we are not going to stop this journey. Is going to be continued. Thank you.
Now, before you say good night, request is please give the names of presenters of the future episodes at least during the first week of this month, not later than that. Thank you.
So Dr. Amol, Amol Pawar. So Amol, we had a talk at Bangalore with another Pawan Kumar.